Thank you so much, and thank you for having me today. I am the Adolescent Program Coordinator for the Indiana Immunization Coalition, which means that I focus on vaccinations between ages 9 and 26, end of college age range. So HPV is obviously one of the vaccines that I am most interested in. So just a little history about the Indiana Immunization Coalition, in case you're not aware. We exist to reduce the spread of vaccine-preventable diseases through immunization, education, advocacy, promotion, and collaborative partnerships. We are a statewide nonprofit, so anyone in the state of Indiana can utilize our services. So today's presentation is going to focus on really 3 different areas. First, I'm going to just do a quick review of HPV as a disease. A lot of times I assume that everyone knows about HPV, but not everyone does. So I'll just do a quick review of that. Then we'll do some education around HPV vaccine and the vaccine recommendation, and then kind of get into the nitty-gritty about HPV rates here in Indiana and ways that we can focus on improving those rates. So HPV, the disease, why should we care? So a little history around HPV, which stands for the human papillomavirus. So HPV vaccine is often thought of being a newer vaccine. But I would like everyone to know that we've known something about HPV for quite some time. So it was first hypothesized that cervical cancer could be caused by sexual activity as early as the 1840s. And that was hypothesized due to the realization that married women were much more likely to get cervical cancer than nuns. And so scientists went about trying to figure out what was the difference between married women and nuns. And of course, sexual activity was one of the things they identified. Then in the 1970s, scientists were able to confirm that papillomaviruses were causing cancer and warts in animals. And then in 1983, it was demonstrated that the same papillomavirus found in genital warts was also found in the majority of cervical cancer specimens. So this research into HPV and papillomaviruses in general has gone back for a long time. So what is HPV? So HPV is the most common STI. It is estimated that 4 out of 5 sexually active adults will contract HPV at some point in their lifetime. The good news is that most of us will contract HPV, have absolutely no symptoms, and our immune systems will work and we will clear it the way that it's supposed to, and you'll never even know that you had it. It is transmitted through close contact and sexual activity. So we've highlighted some different types of sexual activity, as well as sharing of toys and skin-to-skin contact. So I'm just using this to illustrate that it is not just penetrative sexual contact that HPV is spread by. We know that HPV as a virus can live on the skin, and they have found it under fingernails and a lot of other places. So we know that HPV can live on the skin, but the way that it is most commonly transmitted and that we know for evidence-based research is that these are the ways through close, intimate contact. So with every intimate encounter, your risk of HPV increases. Of course, if you have never had any intimate encounters, then your chance for HPV is very low. And so we want to catch HPV, we want to prevent HPV early before any of that exposure actually occurs. HPV is known to cause genital warts as well as several types of cancer. And I have the types of cancer listed here. So I have some interactive slides here, just a little brain teaser for you to try to engage you in the content. So what is the most common type of cancer that is caused by HPV. So all of these are caused by HPV, but think about which one might be the most common. I'll give you a minute to think about it. And while a lot of people probably immediately think of cervical cancer, the most common HPV cancer right now is oropharyngeal cancer. So this is a breakdown of the estimated US cases of cancer caused by HPV every year. You can see that we have 14,000 mouth and throat cancers that are caused by HPV, and those are primarily seen in older white men. The scary thing about that is that no screening test exists for any of these cancers except for cervical cancer. So while dentists can do a tactile exam and a visual exam, and while there are other types of visual exams, there is actually no type of screening test for any of these HPV cancers other than the Pap test for cervical cancer. All right, so now we're going to move on to the HPV vaccine, talk a little bit about the history of the vaccine and the current recommendations. So this is a very old graph, as you might know from some of the things on here. And I would imagine if we have some younger folks on the call, they might be saying like, I don't even know what Zanga or MySpace is. But this is a graph of different technological advances that we've seen, especially on the internet. And I like to quiz you about where you think maybe the HPV vaccine was introduced. So it's going to be right here in June of 2006. So I think it's important to realize that the HPV vaccine is older than Gmail, it's older than Twitter, it's older than Instagram. So when we think about it being a new vaccine, it's actually been around for quite some time. And the HPV vaccine is older than the first official iPhone, which was released in June of 2007. So another just little mind candy there. So the introduction of the HPV vaccine actually went through a lot of different stages, and I could do a whole completely separate presentation on all of that. But I just wanted to highlight some of the changes because I think that's where some of the confusion around the vaccine comes from. So Gardasil, as we know the vaccine, was first introduced in 2006, and it was a 4-valent. So it covered 4 strands of HPV. And then a different company introduced a bivalent vaccine in 2009 called Cervarix. Cervarix is no longer marketed in the USA, but it is still available in other countries. So if you have immigrants, you might see Cervarix listed as the vaccine that they received. Then in 2014, Gardasil 9 came out. They didn't change the name, they just changed it from a 4-valent to a 9-valent. And this is now the most common vaccine in the United States and the only commercially available vaccine at this time. So the original 4-valent was discontinued in 2017. So Gardasil 9 is what you see on the market and what you'll get if you go to the doctor. HPV vaccines were originally only marketed for girls to prevent cervical cancer. So like I said, some of the original findings from many, many moons ago were that HPV was linked to cervical cancer. And they knew that HPV also caused genital warts. And they also knew that it could probably cause other types of cancer, but it was really marketed as a cervical cancer protection. And now we're trying to undo all of that language because really both boys and girls, all genders, should be getting the vaccine. And in fact, some scientists believe that if you were going to only vaccinate males or females, we really should be vaccinating males because they are more successful in the transmission of HPV than females are. So when we talk about valencies, this is what we're talking about. So HPV is a collection of viruses, and there's hundreds. And so we know that certain strands of the virus are causing these different diseases. So the HPV 6 and 11 are what cause genital warts. 16 and 18 are causing 63% of the cancers that cause HPV cancers. And then these other ones off to the right are causing 10% of other cancers. So sometimes we get the question, if I received Gardasil 4, like the original Gardasil, should I go back and be revaccinated? Or if I received Cervarix, which is only 16 and 18, should I get the new vaccine? And the answer is no, for a couple of reasons. Number one, whatever vaccine you had, you are protected against 63% of the cancers caused by HPV, and that's huge. So you got the most protection from those two valencies. So the other valents, 6 and 11, which cause genital warts, and then the other ones that cause the other 10% of cancers, would you like to have protection against those? Absolutely. But the chances are that you have been sexually active since that time, since those vaccines are older, and you've probably already been exposed if you were going to. So the likelihood that you are going to get a lot of benefit from getting revaccinated is not likely. So we, if you've gotten the bivalent or the quadrivalent, we like to assure you that you're pretty well protected. So HPV vaccination in the United States, here's where we're going to start talking about rates. And these are all based on the CDC's national data. So only 62.6% of 13 to 17-year-olds are up to date on HPV, meaning that they are at the, they've either received 1 dose, 2 doses, or 3 doses, wherever they are in their journey of HPV vaccine. And then healthy people, which is now 2030, our goal is 80% of up to date. So we have a ways to go. I have some data here by sex and also by geography. You can see that metropolitan areas are more likely to have adolescents up to date, where rural areas are less likely. And there's a large variation across individual states. So right now, Rhode Island, who has a school mandate for HPV vaccine, sits around 85.2% up to date. And Mississippi, which is the lowest on the list, is only at 38.5% up to date. Then we throw into that COVID, which had an impact on everything, and it impacted vaccine confidence, vaccine hesitancy, vaccine fatigue. And so we've actually seen numbers decrease since COVID. And in most of our other adolescent vaccines, they have rebounded back to the numbers from before the pandemic, but HPV is still struggling to get back to those original levels. So as a result of all of this data, HPV cancers are still high. So we see over 46,000 HPV-related cancers with an incidence rate of 12.5 per 100,000, again, with cervical and oropharyngeal being the most common. So now we're going to get into the recommendation for the vaccine. So if you were going to be recommending the vaccine today to someone, this is what it would look like. The 9-valent vaccine, Gardasil 9, is recommended for all adolescents, all genders, and the ages of 9 to 13 is the ideal destination age. The vaccine is given in 2 doses that are at least 6 months apart. And when we talk about the vaccine at this stage, we really focus on talking about cancer. We don't really talk about the STI piece. And if you're a parent, you might understand why. Nobody wants to go in with their sweet 9-year-old and hear the doctor talk about sexually transmitted infections. I have 2 teenagers, and it doesn't get any easier even when they're older, but definitely at that 9, 10, 11 age range, parents don't want to be thinking about that. But it is important that they think about their children's future and that they think about preventing serious cancers like oropharyngeal and cervical cancer, which we have a vaccine for. So that's where we really focus the message with our adolescent patients. There's also a catch-up recommendation. The vaccine is universally recommended for anyone who hasn't received it up to age 26. So if the first dose is given after the 15th birthday, now we have to change to a 3-dose series. And that's because our immune systems just don't respond the same way as we get older. So in this case, you would give a first dose, and then you would give a second dose 30 days later, and then a third dose at least 6 months after the first dose. So we really recommend that you get that first dose prior to your 15th birthday so that it's only a 2-dose series. But if not, we can still get you caught up to the age of 26. And when we're talking about college students, there's a great bonus here that meningitis B, the Bachelor brand, it is also 30 days apart. So just as a bonus information, meningitis B is recommended starting at age 16. It's especially important for college age students. So when we do clinics, we love to get that first dose of HPV, the first dose of meningitis B, and then come back 30 days later, get them their second dose of HPV, their second dose of meningitis B. So that's one perk of doing the catch-up schedule. So here's another question for you. Do young adults care about cancers caused by HPV? So when you think about college age students and you think about the messages that they care about and why they might be motivated to get HPV, do they care about STI? Do they care about cancer? Do they care about both? I'll give you a minute to think about it. And research has found that they care about both. So going into a campaign that was done at IUPUI, there were some focus groups done and some surveys to find out what college students actually care about. And we kind of assumed that they were really going to care about the STI message because college students and young adults tend to live in the now, but they were also interested in the STI messaging and the cancer messaging. So I think that it's important to realize whatever age we're talking to, that we adjust the message that we're using. So when we tweak the message for young adults, they care about genital warts prevention. It seems like especially young adult males especially care about genital warts prevention. They care about STI prevention, and they care about cancer prevention. And we make sure that we use a message that it's not too late if you've already been sexually active. So, you know, at this age, they may have had 1 or 2 sexual partners, maybe a few more. But knowing that you can get vaccinated and it's going to help protect you, because even if you've, as I explained, we have like hundreds of different HPV strands. You may have already been exposed to 1 or 2, but maybe you haven't been exposed to the rest of them. So we can get this vaccine, help protect you. And just with every encounter that you have, you increase that risk of contracting HPV. So the sooner we can get it in your system and get those antibodies, the better. There's also a late recommendation for HPV, which I'm not going to talk a lot about, but the vaccine may be recommended for ages 26 to 45 years old, again, all genders, and we use the 3-dose series again for that. This is recommended under a shared clinical decision-making recommendation, and it's not super clear what that means from the ACIP, but what we know is that what I just said, with each sexual encounter that you have, you increase the risk that you've already been exposed. And if you've already been exposed, the vaccine isn't going to protect you. There has been some research that has shown that it might still have some protective qualities, even if you have been exposed. But we see this a lot in women who have been with one partner, they got married young, and now they are getting divorced, and they're going to re-enter the dating pool. That would be a great example of somebody who would likely benefit from getting the HPV vaccine. There's no harm in getting the HPV vaccine at this age, but like I said, just the chances that it's actually going to protect you are just a lot less. Okay, so now we're going to talk about Indiana rates. So we're going to start with the bad news. Indiana is 38th in the nation for up-to-date HPV vaccine ages 13 to 17. And we're 35th in the nation, so a little bit better, for having at least one dose of HPV vaccine. So just to clarify what these mean, so we use the term up-to-date because if you have received 2 vaccines and it's not time for your 3rd one yet, or if you've received 1 vaccine and it's not time for your 2nd one yet, you would be considered up to date. First dose is very simply just means that you've at least received 1 dose. And we know there's a lot of protection from that 1 dose, so that's an important one to follow as well. I'd now like to share some information that was provided by the State Department of Health Immunization Director, Dave McCormick, at our recent HPV stakeholder meeting. Some great information here that's been broken down, and I did ask his permission to share it with you today. If you are interested in looking at the HPV dashboard, the link is here. You can go and click on your specific county and see the data, and I believe it is updated quarterly. So please feel free after this to go and visit and look a little more into your rates. So these maps are displaying coverage rates for 9 to 12-year-olds initiating the HPV series and also completion of the series, meaning they got their 2 or 3 doses, depending. Oh, well, for 9 to 12 years old, it would be 2 doses. The counties in dark blue represent rates that are higher than the state average, while the ones in gray represent lower than state rates. So now HPV rates by gender. So this is breaking down female, male, other, and unknown. Just as an FYI, other tends to be when someone didn't know what to put or they were being lazy. So unfortunately, other and unknown don't help us very much. But for females and males, you can see here that over the past few years, 21 in orange, 22 in that gray color, 23 in the blue, and 24 in yellow, that we have been either rising or staying fairly consistent for both males and females. Here's another breakdown by HPV up to date by race. Again, you can see that we've done pretty well at either going up or staying steady. We have seen a little bit of a decrease in our multiracial population, just 1%. And also our Black or African American, we had a decrease just by 1% in the first quarter of this year. But they remain pretty similar. And the Asian population of Indiana has the highest increase in the past 2 years. And we have found that a lot of our Asian immigrants who are coming from different Asian countries as refugees are very interested in getting the HPV vaccine. So that's definitely been a success. These are HPV up-to-date rates by ethnicity. Hispanic and Latino populations are by and far very accepting of the vaccine. So that's always nice to see. And then HPV rates for 13 to 18 years old over the years for dose 1 versus dose 2. So like I said, we're really happy to see that dose 1, but we need to do a better job of getting patients back into getting dose 2. This is a slide I really want to focus on, though. And I think this is something that really should be concerning to everyone who works in healthcare. At the 11 to 12-year-old age range, there is a school requirement for Tdap and meningococcal. We call them the 6th grade shots because that's typically when they are needed. And so we see these high percentages, and you can see I said it went down a little bit and then we've been recovering. we're doing a great job with Tdap and meningococcal in getting adolescents into the doctor and getting their vaccines. But, excuse me, the problem is that we have missed opportunities with HPV. So we know that these adolescents are in the doctor's office. We know that they are receiving vaccines, but they're not getting the HPV vaccine. So it's a real missed opportunity where they really could be getting all three of those vaccines at the exact same time. And that's something that we really need to focus on as healthcare workers, healthcare providers, is making sure that we're not missing an opportunity when a patient is in the office and they're eligible for HPV, that we're offering it and we're giving a strong recommendation around that. So where are we right now? We are at 54.2% among adolescents 13 to 15 years old. And then on my little dial here, I have the star at the 80%, which is our goal for 2030. So you can see, while we may not be the worst state, we definitely have room for improvement to get to that 80%. So how do we move the needle? So I'm going to talk about 4 different types of best practices that you can hopefully communicate with people that you work with in healthcare that have been proven best practices for increasing HPV rates and for communicating with families. So the first one that I would like to talk about is the whole office intervention. The whole office intervention is exactly what it sounds like. It's making sure that everyone in your office is on the same page with the same message about HPV. Patients, when they come into the office, they have multiple touch points, and you need to make sure that you have a consistent messaging. And you may think that's kind of silly, like, why does my receptionist need to know about HPV? Or why does my MA need to know about HPV? And the reason is that any person who is with your office is representing your office and representing a healthcare provider's recommendation. Even though you may not think that way, the person answering the phone even is a representative of the office. So we have heard multiple stories of patients calling to schedule a well-child visit, and then they will say, what vaccines does my child need this time? And they'll tell them, well, there's only 2 school required ones. And then when they come to the visit and they've told their child, you're only going to get 2 vaccines, and they say, oh, but there's a third one, you already have a barrier. You've already set up a barrier in your communication with your patient. There's also a chance that the person on the phone could say something like, well, you have to have these 2, but I wouldn't get that other one. Or I've heard bad things about that other one. And you might be laughing, but it's happened. The same thing with arriving at the office when the medical assistant is bringing the patient back to the room, when they say, yeah, and you're going to need to get 2 vaccines today. Again, already putting a barrier in place for the provider. And then lastly, we had a situation where a doctor was making a really strong recommendation with patients, and then, writing the order, everybody was on the same page. Then the nurse came in to administer the vaccines, and she was saying something like, oh, you don't really want this one, do you? It's for people who have lots of sex or something like that. And then the parent saying, oh, well, no, I don't want that, and not giving it. We also had a situation where the nurse in charge of ordering vaccines did not believe in HPV and therefore would simply not stock the vaccine. So even though the doctor was continually making a good recommendation and saying that they wanted the patient to receive the vaccine, then the nurse would come in and say, oh, well, unfortunately, we're out of that vaccine today. So it's really important that we make sure that everyone in the office is on the same page and giving the same strong message that HPV is something that we recommend and that it's recommended the same way as the other 2 vaccines that are recommended at this age and required for school. So who is the most trusted source of medical information? So this is according to many different researches, but more recently, there were some done by Unity for teen vaccination, and we find the same result every time. So I'll let you think about it for a minute. And while you might think that the internet or the CDC or friends or family might be the answer, it is actually healthcare providers. So time and time again, research has found that while they might consult lots of different sources of information, that most families, most citizens have the most trust in a healthcare provider. And again, healthcare provider doesn't just mean the doctor. A healthcare provider can mean the pharmacist, it can be the nurse, it can be the medical assistant. So it's really important that if you are someone who is considered a healthcare provider, that you use your words wisely and that you make sure that you're giving a strong recommendation, because what you say really matters to your patients. So piggybacking on that, we're going to talk about the presumptive approach, which is another evidence-based practice to recommending the HPV vaccine. So the presumptive approach looks something like this. Your daughter or son will get 3 vaccines today. Tdap to prevent pertussis, the first dose of HPV vaccine, which prevents cancers, and meningococcal vaccine to prevent a serious brain infection. I strongly recommend all 3. What questions do you have? So the reason the presumptive approach works so well is that, number one, you are presuming that they are going to get the vaccines. It's not a question. It's not, I'm going to throw it out there. It's, I'm presuming that you will get these vaccines. You're going to get them today. So we're going to do all 3 of these vaccines today. It's not, but if you can wait if you want to, all 3 today. Explaining the 3 vaccines in a concise manner and bundling them with HPV in the middle. So this is a problem that we see. Some providers will call out HPV separately. So they'll say Tdap to prevent pertussis and meningococcal. Then you can also get HPV vaccine. So we don't want to do that. We want to make sure that we're bundling them all together, all 3, to show that they're recommended the same way. And then I strongly recommend all 3. Again, that strong recommendation from the healthcare provider is the biggest predictor of vaccine acceptance. And then what questions do you have? Showing that you are open if they have any questions. This presumptive approach is very effective. It's very, very easy. Providers who are hesitant to get into a big conversation about HPV vaccine, this is a great place to start, because it's something that you can practice. It's bundled together in a nice, concise manner, and it's easy to do. So this is very highly recommended. So you've asked, do you have any questions? And they might have questions, and that's okay. I think that it's common for us to automatically assume that people are not going to get vaccinated as soon as they ask a question. But as a mom and as someone who works in vaccines, I can tell you that I even have hesitancy at times in the doctor's office. And if any of you have children, I'm sure you've experienced that as well. And so asking a question does not mean refusing the vaccine. Asking a question does not mean that you are running in opposite directions. So when a hesitant parent is asking a question, it's great to respond with this motivational interviewing technique. So motivational interviewing starts with asking their thoughts on the vaccine, and then listening really carefully with a goal of understanding what they are saying. So sometimes we listen, meaning that we sit there and the words are coming out of their mouth, but we're really just waiting for our turn to speak. So really listening to what they're saying so that you can understand. And then, this is the most important part, don't just start offering your unsolicited advice. Ask if you can share what you know about the vaccine. Psychologically, it has been shown that if you ask someone, do you mind if I share what I know about that? And they say, yes, go ahead. Then that automatically makes them more open to the information that you are about to share because you've had a conversation with them and they've consented to taking that information. So then once you share what you know, and again, it should be concise and confident, then you can ask open-ended questions like, what do you think about what I just shared with you? Does that make you feel better? Asking some questions and trying to focus back on the positive aspects of the vaccine. And really, again, listening and showing that curiosity about their hesitancy. So the way that this might look is a patient saying, I'm not sure that I want that vaccine. I've heard that it can cause infertility. So you might say, I can understand, that would worry me too. Where did you hear that? And they might say, oh, my friend's sister said that da 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 da. Listen. And then say, do you mind if I share with you a little bit that I know about that? And they'll say, yeah, I would love to hear that. Most times patients are going to say, yes, they want to hear more. So then you can talk about all of the research that's been done around the HPV vaccine, and that the HPV vaccine actually helps you preserve your fertility, because cervical cancer is one of the ways that women at young ages end up needing to have hysterectomies or other complex surgeries. And so by having this vaccine, it's very protective, 99% against cervical cancer, and that any claims about it causing infertility are absolutely unfounded through years and years of research. And then you can ask, how do you feel about that information? How do you feel about what I just said? And they may say, well, I understand what you're saying, but my friend's sister had the vaccine and then she lost her fertility. Again, understanding the question. I can see how that would be really scary. And I understand that your friend is probably really upset about not being able to have a child. However, I'm wondering when they got the vaccine, because the earlier you get the vaccine, the more protection you have. It is 99% effective if you get it early, and that's why we're recommending it at this age. So those are just some examples of how motivational interviewing can work to really help someone understand the vaccine and overcome hesitancy. The last thing that I wanted to talk about in terms of making the recommendation is the 3 C's. This is a newer program from Unity for Teen Vax. You can go to unityforteenvax.org/3CS. And this is a program with some video modules and some other things to learn about making a recommendation for adolescent vaccines that is confident, concise, and consistent. So many of the things that we've already talked about are kind of rolled into one program here. So that confident recommendation, like, I'm confident about this vaccine, I support it, I think that you should get it. It's a strong recommendation. Concise. So again, not calling HPV out separately, not going into a big thing about, sexually transmitted infections or things like that, but just making a really concise recommendation, and then making a consistent recommendation. So if your patient decides this time, I don't know enough about this vaccine, I'm going to have to think about it. That's okay. But the next time that they're in there, you need to be making that exact same recommendation, that confident, concise, consistent recommendation. Like, just because a year has gone by doesn't mean that I've changed my mind about the HPV vaccine. I'm still going to tell you that it's recommended for your child's age. It's a good vaccine that prevents 6 different types of cancer, The best time to get it is right now when they're young and their immune system is going to respond really well. And can we go ahead and get them vaccinated today? So this is a great program if you have providers that are looking for a little more guidance around addressing hesitancy with adolescent vaccines overall and with HPV specifically. Okay, and then as we wrap up, I'm just going to share some resources from the Indiana Immunization Coalition. We are happy to help you in any way that we can. So I first wanted to highlight our mobile immunization clinics. So during the pandemic, we received funding to start a mobile immunization program. And our focus is really to overcome economic and racial disparities. So we have clinics all over the state. We take our little van full of stuff and our staff, and we go to places where the community gathers, libraries, churches, community centers, schools. And we go in, we are able to offer all vaccines. We are able to offer vaccines at no cost. So we do accept insurance if you have private insurance or Medicaid or Medicare. If you do not have vaccine coverage, we're able to utilize federally funded programs to give free vaccines. We try to have our clinics during hours that people find convenient. So whereas sometimes health departments are very short-staffed and can only be open a few hours each week to offer vaccines, we try to have evening hours, weekend hours. We go during the school day to schools. We have lots of translation materials. I believe our consent forms are now in like 26 different languages. And we have interpreters on site in areas that we know we will need them. And we always accommodate walk-ins. So this is a really great service. There is no cost. If you have a place that you think could benefit from holding a vaccine clinic, you could go to our website and submit a request and someone will get back to you. We basically just need some space to set up all of our stuff, some chairs and tables and electrical outlets, and we bring all of the staff and vaccine and materials. So we're happy to help in any way that we can in offering these clinics. We also have several programs online if you are interested in checking them out. VaxChamp is a continuing education program. It's module based, and we currently have programs for both pharmacists and dentists that focus on making vaccine recommendations in non-traditional environments. And HPV is featured in both the pharmacist and dentist modules. Again, this is free. So if you have any pharmacists or dentists that might be interested, please check out vaxchampion.org. Project HPV-Free Collegiate Toolkit is something that I am the co-author of with Dr. Katie Head from IUPUI. And this was based on a program that was built for IUPUI around educating for HPV and holding a clinic. And it was very, very successful. So we made it into a toolkit that can be used at colleges, no matter how big or small. And it's completely free. It is online. We've had a lot of success with this toolkit. It's won some awards in Georgia. We've had participation from anywhere from the University of Nevada all the way up to William and Mary in Virginia. Purdue runs it every year. It has a lot of information to help promote HPV vaccine on your campus, to help get staff trained if you have a if you have a student health center, getting those staff trained as well, and then also how to partner with communities so that if you aren't able to offer the vaccine on campus, how can you partner in the community to do so? So we have lots of free stuff there. We also offer an HPV Part 3 maintenance of certification. So for physicians who need those MOCs for their recertification of their credentials, we do offer an HPV quality improvement MOC that they can participate in. Again, that is free, and you can find out that on our website. And then lastly, we are a partner with the International Papillomavirus Society for International HPV Awareness Day on March 4th. So every year on March 4th, we have lots of fun stuff that we do. We hold special webinars. This year we had a day at the State House. We do lots of different things. So if you're interested in participating on March 4th, you can always reach out to us, and we would love to help share the love for International HPV Awareness Day. Online at our website, vaccinateindiana.org, you can find our resource catalog where we have tons and tons of stuff that is all free for you to order. I've highlighted just a few things here. Over on the left, we have our HPV flyer that talks about protection against cancer. The center picture is our Who's Your Stories, which is stories about people who have suffered from vaccine preventable diseases. We have several for HPV. The one shown here is Kristen Forbes, who died of cervical cancer at 23 years old, and her family is from Noblesville. And then over on the right, we also have some documents about communicating with patients about vaccines. We have some frequently asked questions, things around vaccines and autism, things around vaccine reactions, things that are included in vaccines. So all of that information we have available. And then over on the right as well, we do have some fun swag as well. We have some rubber bracelets and buttons and things like that. So if you're looking for some things to spice up your HPV game, we have some of that as well. And then I wanted to put in one last shameless plug. The National HPV Conference is the first ever National HPV Conference, and it will be held in Indianapolis in 2025. This is a brainchild of mine and some other folks here in Indiana, that we do not have a national HPV conference right now. And we're going to try to bring together as many people as possible from across the US so that we can talk about moving the needle for HPV, because we know that there's a lot of really great work going on across the nation, and maybe we don't know about it. And so if we can get together and we can share, then hopefully we can, have a united front against HPV. So if you're interested in learning more about that conference, you can go to nhpvc.org. We also have a presence on Facebook and Twitter. So that is the end of my presentation. I'm so thankful that you joined us to learn a little more about HPV and how we can move the needle. I am happy to connect with you. I am happy to come and talk to groups or to providers. I'm happy to help you with resources. If you find that you need a resource and you can't find what you're looking for, let me know. We may be able just to make something for you. We have social media you can share. I'm all about sharing the love with trying to make a difference in the realm of HPV. So thank you so much for listening, and I'll take any questions if there are any.
Thank you so much, Sarah. This is Allie Orwig. I apologize for missing the start of the session, but what wonderful information, and how cool the inaugural conference will be right in our backyard in Indianapolis. Hopefully many of our health departments or rural health clinic staff will be able to attend that. Very cool, very cool.
Yeah, very exciting.
I don't have any questions that have come in yet. We can give it just another second or two here, but I appreciate you sharing your contact information. Certainly anybody that comes up with questions after this is posted, reach out to Sarah there at sarah@vaccinateindiana.org. And I know that her and the whole organization at the Immunization Coalition will be happy to help you out.
Yes, absolutely, absolutely. And thanks so much for hosting us today. This is something that's really near and dear to my heart. You hear people talk about we need to find a cure for cancer, and maybe we're not there yet, but we definitely have a vaccine that can prevent some. So we need to get the word out about it.
Indeed, indeed. Well, thank you again for your time today. we'll have this up, not by the end of this week, but certainly by the end of next week. And if there's anything else we can do or any other programs you have in the future, please let us know.
Great. Thank you so much for having me. Take care.